There. So, hi, Patrick. Welcome to the Big Unlock podcast. And it is great to have you with us today.
Thanks for
I'm
having me.
Rohit Mahajan. Yeah, thank you. I'm Rohit Mahajan. I'm the managing partner and CEO for Big Rio and Demo Consulting. And Patrick, the Big Unlock podcast was started by Paddy Padmanabhan, who's the previous, he's the founder of Demo Consulting, and it has been a very successful podcast with many healthcare leaders on the podcast. So it's great to have you here. And would you like to introduce yourself to the audience, please?
Sure, yeah. Patrick Mobley, CEO and founder of Vivid Health. Little bit about my background. Speaking to Rohit today from Raleigh, North Carolina. Grew up around healthcare. My dad was a physician, and then kind of found my way into the startup game. Was very early at an employee company called Evolent Health, where I really just did all sorts of things. From I started on the clinical side, I ran their Virginia market, ran a lot of their value-based care operations. I went to Aledade, where they aggregate independent providers, moving them to risk-based arrangements, and we grew from about 20 practices to 220 during that time. Went to Bright Health, ran a large health plan in the Mid Atlantic, and saw across all three of those what high growth looks like from a company perspective, but always wanted to do it myself at least once, and so got to know the leadership at Redesign Health. I had hired a company that spun out of them. And for those that don't know, Redesign is a venture studio out of New York. It's backed by General Catalyst, UPMC, CVS, Aetna, among others. And got to know them, and we eventually came up with the idea for Vivid, which was really reflective of a lot of the experience. I know we're going to get into it, so I won't spoil it all in my intro, but it's really targeted at making clinicians' lives better.
Right, right. So that's so interesting that you have had such a deep career in healthcare, Patrick. So what got you? What was the early on catalyst that kind of started you off in this direction?
Well, like I said, like my
Yeah,
uh being around my dad and being in his
yeah,
clinic my entire childhood,
yeah,
it's a very comfortable setting. And then knowing how hard he worked, and just the long hours he put in, and frankly even seeing often the unscripted stuff you don't see in the practice, which is
yeah,
frustration with paperwork and admin work,
yeah.
and just the things that could slow him down. And it was inspiring to see his hard work. It's always an interesting area to get into, and then thinking that I could build something that might solve some of the things that gave him headaches was certainly exciting.
That is awesome to know. So I know that you mentioned Vivid already, and it came out of Redesign. So Patrick, please tell us more that what is your thesis at Vivid Healthcare, and what kind of problems are you solving, and what are you working on?
Yeah, so in those prior roles before Vivid, I had a lot of nurses either work directly with them or had them report up through me. And one of the things that just stuck out to me was, how much time it took to call a patient, assess a patient, build a plan around the patient, and follow up. And those are four steps that are really important in a risk-bearing organization that's looking to manage cost and manage potentially high cost individuals, close care gaps, improve risk adjustment. And so I wanted to figure out a way, as I'll probably say more than once on this podcast, but to leave the nurses with nothing left to do but provide care. And I say nurses, but I mean nurses, LCSWs, community health workers,
Mhm.
uh, really the whole gamut. And so in coordination with Redesign, we started exploring sort of the capabilities of what generative AI could do, and where could we take like very tactical workflows that were already deployed in organizations, but automate them. And that's what we've done from the moment of intake and referral, where we can use an AI agent to call a patient, or we can text or email a patient as well, assess them, take assessment data, push it through a large language model, create a care plan, take that care plan, have it approved by the clinician, and then automate follow-up with the patients thereafter, is something that whether the patient is with the practice for a day or for 6 months, it's a
Mhm.
platform that fits each one of those circumstances.
That's great to know. So what is it that you think, makes the platform so unique, Patrick. And you were one of the early adopters of Gen AI, having incorporated a large language model in the clinical workflow. So was
Yeah.
that hard to do? Was that easy to do? And how are the results of that coming up now?
Yeah, it's well, it certainly wasn't easy. We had good partners like your organization at Big Rio,
Hmm.
to build it out. But um, we felt that if we could cover a lot of specialties and conditions, like for a nurse, it's about understanding sort of the mental and physical aspects of what they're managing, and like I said, taking that data and creating a care plan, but always leaving the provider with the control over what the AI puts out. In fact, I didn't mention it earlier. We own the trademark to provider-led AI. Like we felt that it was really important to understand that, like for all the good that AI can create, the providers still have a final say. And
Yeah.
so we take all that good. We again, like we can have an agent call a patient, enroll them in chronic care management, or assess them across the Oasis documentation in a home health environment. Um, Build plans and really let the nurse focus on the care coordination aspects of the care. And then one of the things that was most important
Hmm.
was if we were really good at the front part, if we were good at engaging the patient and we're good at assessing and we're good at uh, managing, they could probably be able to scale. We often say we want to amplify our nurses and our care teams on a very individual basis. But if you're really good at that front end part, you've got to figure out a way to manage the back end. Because if they're managing extra patients, the last thing you want is a nurse to think, "Oh my gosh, I went from 10 patients to 20 patients, and this is too much work." So we thought through that, and that's why I say the platform works through the entire episode, because we automate follow-ups. We can have the agent call, we can text, we can email. The nurse doesn't have to do anything, and all the nurse has to do is turn on the platform, look. She can see how the patients are stratified,
Hmm.
and then look at specific notes that have been collected from, if it's voice calls, from the voice calls, and then
Hmm.
take actions on that. And it really allows scale and reach that for a risk-bearing organization or a home health organization, it doesn't really matter, that you just can't get with any other platform.
I see. I see. So is that where the positioning of the platform is also, Patrick, tell us a little bit more about who are the kind of, potential customers or clients or users of the software platform.
Yeah, there's really a couple of distinct markets, although I often refer to what we've built as like the perfect puzzle piece for
Hmm.
any organization. So, one key market for us is primary care space, where whether they're, I think it's good for a risk-bearing organization, but even if they're not, and they just want to look to provide extra care and generate additional revenue, we can deploy our agent to enroll patients in chronic care management, and assess them and all the required documentation for chronic care management, as well as annual wellness visits, as well as transition care management visits. We're seeing a 100% reduction in outreach specialist labor from our voice AI tool, and a greater than 50% reduction
Hmm.
in cost compared to competitors in using our tool. We also, so that's the primary care market. We also target the post-acute care space, so home health and hospice. They have probably the most onerous documentation requirements of anywhere. That there's a form in the home health side called Oasis that's 27 pages long and over 200 questions. The
Hmm.
most number of patients a nurse can see a day is two, because it's just so much work to get through that paperwork.
Yeah.
And so we've automated the whole thing. We've got it to the point where when the nurse enters the door, she needs to validate the Oasis, but the Oasis answers are received, the care plan is created, and really, instead of that initial visit being just one long Q&A session, it's really about care and about how to do something that's really valuable to the patient. And so we target that market. That market, we're seeing a greater than 50% reduction in
Hmm.
documentation time, which has a downstream impact to revenue if a nurse can see an extra patient given his or her extra time. Hospice. Hospice is
Hmm.
about to go through a massive transformation to a form called Hope. It's kind of like
Hmm.
Oasis, just a little bit smaller. And we're essentially deploying the same technology that we're using for home health into hospice, and I know we're going to see the same results. last thing I'll say is like we cover 100 conditions and 16 specialties. And so if we're getting a lot of interest from palliative care organizations, non-skilled nursing organizations. We're seeing uh, some specialty organizations begin to kind of try to understand what we're doing. But once they see the platform end to end, it really resonates pretty quickly. So really proud of what we've created.
That's amazing, Patrick. And I just heard you say, and I know this from before as well, that you talked about chronic care management across many disease conditions, that you have this bunch of surveys, so that's all your intellectual property, right? So that is what you built as in fact, I think early on, the core of the system. So could you describe that a little bit more in detail on how it adds value and what it actually does?
Yeah, yeah, and there's a little bit of a story to it. So in prior
Yes.
organizations, and in fairness to these organizations, it was the right thing to do, but they really focused on like kind of five large conditions: CHF,
Mm-hmm.
COPD, CVD, depression. But I always felt that for the patient that maybe has COPD, but also has kidney disorders as well, like that kidney disorder may have a direct impact on
Mm-hmm.
their COPD,
Mm-hmm.
nothing else than at least their mental state. And so we wanted to be pretty broad in what was available to a nurse to evaluate a patient. And the second part to that is the way the questions were structured, which we wanted to be able to evaluate a patient across both their mental and physical aspects. What I mean by that is, not only do you have uh, soreness here or there, or chest pains or ankle swelling, but also, do you have anxiety around paying for your meds? Do you have transportation? Do you have
Mm-hmm.
relatives nearby, and it creates this really holistic view of a patient.
Mm-hmm.
Some of the feedback we've gotten, which I think speaks to the method that we've deployed, is that, if a nurse or clinician, really could be any clinician, is sort of guiding you through or hovering over you while you answer a set of questions, you feel this need to answer in a certain way. When it's delivered either text, email, or voice, that goes away. And what we're getting back from the nurses is the answers are much more honest and clear, and it's
Mm-hmm.
providing detail that they didn't have prior to engaging with us.
That's very cool to know. So, when you're thinking of this in a larger setting, Patrick, obviously you might need to think about how it integrates with the systems that organizations might already have in place. So, what is your approach to that, and
Yeah,
how do you make it easy for your customers to use it?
yeah. So I think there's three paths there. One, just straight out of the box, the platform works really well as a standalone platform. Can do everything we've talked about so far. Does really well. Second part of that answer is we use Fire Server FHIR.
Mhm.
That creates a data standard for us to push and pull information from and integrate, frankly, with most EMRs. And so
Mhm.
we're fully capable of integrating with just about every EMR in the market. The third, and it's the most interesting, is we partnered with an organization called No2, which is part of something called a QHIN. And I know I'm getting kind of technical, but QHIN is QHIN.
Mhm.
And what that is an interoperability layer to our platform that allows us to push and pull data from just about every EMR instance in the country. For example, every single hospital in the states of Washington and Oregon are on this QHIN. So
Mhm.
as I sit here today, while we may not be directly integrated into OSHU in Portland, we can access their EMR, we can push and pull data, we can make requests.
Mhm.
And I really think, like, bigger picture beyond Vivid, that capability is going to be table
Mhm.
stakes for any organization entering the digital health space.
I see. I see. So that is great to know. So, tell us where you think the future is, Patrick, and what are some of the early findings that you have from your client implementations, and where are you headed in the next few weeks, months?
Well, hopefully a lot of growth. We're certainly
Yeah.
seeing a lot of interest. There's no limit of folks that want to talk to us, engage with us, understand what the platform does.
Mhm.
I think, like, what we've seen, and it's been kind of entertaining to watch, is when we go through our demos and what the platform can do. On the voice side, we'll have them call the agent and speak. Her name is
Mhm.
Sage, and just the faces light up. Their creative juices start flowing. They start thinking like,
Mhm.
what are the many different places that they can deploy this agent? Because you got to think of her as like an employee that doesn't get tired, that can work 24 hours a day, that you only have to train once,
Mhm.
and it's incredibly powerful. So I think like all phone calls that aren't that don't require clinical decision making will ultimately be done by agents like this long term.
Mhm.
And across specialties, it doesn't really matter.
Mhm.
And then the third thing, like more, going way out in the future, I think that we'll, at least within our platform, we'll start to deploy different types of agents. So we talked about voice agent, which is one type.
Mhm.
Another is one that will take all the data that we've acquired, um,
Mhm.
and maybe we're not directly integrated with an EMR, but we are using the agent to go into that EMR and deploy data in specific sections of the EMR. I was at a conference last week, and the part of the conversation was, does the EMR just become the file cabinet for everything, but all the action happens in applications like Vivid? And the idea is that because of these QHEN that I referenced earlier, it's going to allow pushing and pulling data, and
Yeah.
the agents can take it and put it into the specific spots it needs to be. So maybe the EMR stays the source of truth or system of record, but the actual technical capabilities and advancement, and frankly, the efficiencies that AI will bring or live uh, a layer above that, and that's where the clinician does a lot of their work. I could see that definitely happen because I think the agents will be able to operate everyone's computer at some point.
Yeah, that's true. So, Patrick, just shifting gears a bit because you mentioned value-based care, and that is something that you have been very closely associated with. Is that what is the macroeconomic or other trends that you are seeing, whether it is value-based care becoming more, prevalent, or any others that you see are coming up our way?
Yeah, so I think having lived in that world for many, many years,
Mm-hmm.
um, the I don't think it's going to entirely go away. We're not at 80% market saturation with primary care being in a risk-based arrangement. I think the numbers in an MSSP, I want to say it's like around 40 to
Mm-hmm.
45%. Might be off
Mm-hmm.
a little bit there, but it's somewhere in that range.
Mm-hmm.
Um, but I think what's interesting is the the way that, like, pre-AI, the way that organizations worked with an independent primary care or maybe even a health system was that you would deploy a lot of nurses and staff to find the sickest of the sick, manage them really, really well,
Mm-hmm.
try to bend the cost curve, and then there's a way to make money based upon how well you've saved. I think with AI, and I should mention that a lot of those organizations, their deal terms, basically for every dollar, 50 cents goes to the company and 50 cents goes back to the provider. I think the revenue opportunity for the provider is going to go up because the cost of providing those services is going to go way, way down thanks to AI. So instead of deploying an army of people into an ACO, the agent can make all the same phone calls, can do all the same engagement at a
Yeah.
fraction of the cost. And now it's going to look a lot more appealing to a primary care doctor who, instead of making 50 cents on the dollar, can make 80 cents on the dollar. And I think as those models continue to mature and this technology sort of marries with it, it may accelerate, but we'll see. And I think there's a lot of contingencies in what I'm describing, but I think that there's certainly a path there that could be really interesting.
Right. Any other regulatory, changes that you are seeing that might impact the business model, or any other, things coming up in the future, Patrick, which you would like to share as a part of the closing remarks? We're getting to the, end of the podcast here.
Yeah.
Anything that else you would like to add to the conversation, to the
I
audience?
think that like it'll be interesting to see whether it's federal or state governments that ultimately dictate like individual AI regulations in healthcare. You'd
Mm-hmm.
prefer it to be more federal than state, or else you end up with 50 sets of rules that every company has to manage.
Mm-hmm.
Um, and so it'll be interesting to see, like, you had this discussion last week as well, is you want a standard, you want everyone to kind of be playing by the same rules. And
Mm-hmm.
so and if it doesn't happen fast enough on the federal side, the states are going to figure it out themselves. And and that's going to it's going to make for kind of unintended consequences for an organization that wants to be in multiple states or wants to partner with, and that's not true for just us. That would be true for OpenAI, who may have a different rule in 50 different states. And so having a set of standards and regulations to help sort of manage what is coming bigger than Vivid, just AI in general, is probably something that we should all be keeping an eye on.
Great, great. So thank you, Patrick. We are at the end of our podcast today. This was a very interesting discussion. And, I like to say agents are coming and they'll be part of the digital workforce. And you've already embraced, Gen AI very early on and made it available to your customers. So thank you very much for being a guest on the podcast and looking forward.
Thank you. Yeah, it was great. Appreciate you having me.
Absolutely. Thank you, Patrick. I'll stop the recording now.